Hi, good evening, everyone. So today's talk is the Vignet on vagal nerve stimulation therapy, and this is a new emerging therapy that we are looking at. Uh, 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 the This is how the X-rays you may actually end up encountering. A patient may have an ICD, and there is another lead which you can see on the opposite side, and the lead is actually tunneled through into the neck on the vagus nerve, and this is what is a vagal nerve stimulation therapy or baroreceptor autoregulation therapy as it is known, and it is one of the recently approved therapy by US FDA in refractory heart failure. So this all started with the multiple trials. We now have a lot of data emerging for it, but the first in our part of the world was part of the Anthem study, and this is the publication that happened when I was author and lead investigator from my center. And this was published in JACC. I was fortunate enough to do the world's first vagal nerve stimulation device implant in a refractory heart failure. And now we have recently published even 7 years follow-up and a long-term follow-up from the Anthem and Core study. Basically, this study was to look at the improvement of LV function and heart failure symptoms, and the objective was to evaluate whether autonomic regulation therapy, also previously called as ART, with the left or the right side for the treatment of chronic symptomatic heart failure with reduced ejection fraction. Firstly, it was looking at its feasibility and tolerability. Secondly, at the primary endpoint, which was the incidence of procedure device related AEs at 9 months initially, and then it was followed up into ENCORE extension and ENCORE studies, which also looked at into the long-term follow-up up to even now 7 years follow-up. And they also assessed the efficacy outcomes in terms of LV ventricular ejection fraction and end systolic volumes at 6 months. They also looked at the overall in the study into the LV end diastolic diameters, quality life as assessed by 6 minute walk distance, quality life by Minnesota Living with Heart Failure Questionnaire, functional NYHA class, heart rate variability, and biomarkers like HSCRP and NT-proBNP. These were the various sites, and I was principal investigator from the clinical site of Sanjeevani. There was Medanta, KIMS, and multiple other hospitals that were part of the study. So the trial actually, the study actually looked at the beyond consenting, the left versus right side randomization. And then there was a titration. So every follow-up, the output and the cycles were modulated and regulated for 10 weeks. And this cyclic venous therapy was then followed up for 6 months, looking at the outcomes every 3 months. So what it is, basically, it is the device which has got already multiple implants, more than 1 million implants now worldwide in epilepsy and refractory depression, where it is implanted on the left or right vagus nerve by a carotid dissection by neurosurgeons. And of course, the lead doesn't go to the RV lead. So the only thing that goes is a pectoral generator, and then it's implanted through the tunnel into the carotid artery, carotid sheath into over the carotid nerve, through that into the carotid sheath to the vagus nerve, and that's how the polarity is towards the brain in patients with refractory epilepsy. All that has been now done is the polarity is reversed, and now the current goes from the vagus nerve towards heart rather than going towards the brain. So chronic intermittent stimulation was devised with 10 hertz of 250 microsecond pulse width, with VNS intensity was titrated over weeks to maximum tolerable current below the threshold of side effects, that is alteration of voice or hiccups, which was the only side effect noted. And ECG was monitored to confirm no acute changes in the heart rate. Over time, the side effects they went off as the with the time went by. An average stimulation current was 2 to plus minus 0.6 milliampere. These are the baseline characteristics, left versus right. You can see not pretty much any major difference. Most of the patients were male. You can see that class 2 patients and class 3 patients, there were some more, almost equal amount, though slightly more in class 2. Baseline EF was around 32%. LV end systolic dimension of 51 and LV diastolic dimension of 62. So these were pretty much enlarged heart with a baseline heart rate of 78. These patients were already on beta blocker, and none of these patients previously had an ICD. The one that you saw was the later images that may be emerging. You can see that almost 100% were on beta blockers, 83% to 87% on AS or ARB. Remember, this is a pre-ARNI study. Aldosterone antagonists, digoxin, and loop diuretics were also there for the symptoms. And you can see that commonest side effect that was found was the cough or oropharyngeal pain. Otherwise, there was no local implant related infection, and unrelated events or pooled were more, but related events were not many. So primary efficacy outcome, you can see that the left ventricular ejection fraction, though, did not change much in this, improved drastically by 5 to 10%. But what was most significant was the LV end systolic volume, which reduced. You can see these all values: LV end systolic volume, NYHA class, 6-minute walk test, Minnesota heart failure questionnaire, heart rate variability, heart rate drop by 3 to 4 beats, and NT-proBNP was not significant, but CRP values were significantly reduced. So to conclude, Anthem HF approach to ART on either side, left or right, was feasible, well tolerated, not any safety concern, with improvement in the cardiac function and heart failure symptoms, and further investigation in a controlled study was recommended. And then it came Anthem HF, was followed up with by Anthem, followed by Anthem long-term follow-up, and then came Encore, and then Encore extension, and we all have published these multiple papers. But what has happened is now this is another device, not the same device, which has got FDA approval for its trial that has been done in the US and the other part of the world. So this is Baroreceptor device, which is actually approved for the same therapy in patients who have refractory heart failure, who have narrow complex, who are not eligible, or CRT, or who are symptomatic despite ICD or CRT. Those patients were only eligible. And narrow complex patients, this is the new proposed new algorithm. Of course, it's not something that's been implemented yet, but you can see that anybody who's got narrow QRS and ICD is already done, and patients still remain symptomatic in class 3, these are the patients you can consider for BAT, that is autoregulation, baroreceptor autoregulation treatment. So it can be with or without ICDs if the patient is not eligible for CRTs, that is. And of course, in class 4 patients, you would still stick to the CRT and ICDs, but class 3 patient is placed where this therapy can still find a role. And with waiting for the new outcomes, maybe we'll have it for class 2 as well later on. Thank you.